The record now?
Yes. You need to stop.
Okay. Can you hear everything? All right. So welcome, everyone. This public hearing before the Health Systems Planning Unit, identified by docket number 18-32278-CON, is being held on April 9th, 2019, to consider Hebrew Home and Hospital's application to terminate its chronic disease license and establish a behavioral health facility. This public hearing is being held pursuant to Connecticut General Statutes, Section 19A-639A, and will be conducted as a contested case in accordance with the provisions of Chapter 54 of the Connecticut General Statutes. My name is Damian Fontanella. Victoria Veltri, the Executive Director of the Office of Health Strategy, has designated me to serve as the hearing officer for this matter. My colleague, Hannah Nagy, is also here to assist me gathering facts related to this application. Additional staff present from the Office of Health Strategy are Leslie Greer and Juliet Manolin. I'm going to ask you at this time to please make sure that your cell phones are silent or off. The Certificate of Need process is a regulatory process, and as such, the highest level of respect will be accorded to the parties, members of the public, and staff. Our priority is the integrity and transparency of the process. So accordingly, decorum must be maintained at all times by the parties and public present during this proceeding. Should any member of the public have any questions or need assistance, please raise your hand at any point, and Leslie or Juliet will come and assist you. It's also important to note that this hearing is also being recorded, and the video recording will be uploaded to the portal after this is completed, as well as the transcript. All documents related to this hearing have already been uploaded or will be submitted to the Office of Health Strategy will be available for review on the Office of Health Strategy CON portal. Instructions to access the portal are on the information sheet, which is available at the check-in table. In making our decision, the office will consider and make written findings concerning the principles and guidelines set forth in Section 19A-639 of the Connecticut General Statutes. Hebrew Home and Hospital has been designated as a party in this proceeding. At this time, I will ask Hannah to read into the record those documents already appearing in the unit's table of record in this case. All the documents have been identified in the table of record for reference purposes.
Okay.
Hannah?
Thank you. Good afternoon. My name is Hannah Nagy, and I'm a planning analyst for the Office of Health Strategy. At this time, I would like to read into the record Exhibit A to Exhibit N.
Thank you. In addition to the documents identified in the table of record, as discussed with the applicant prior to the hearing, Exhibit N, which is the notice of appearance for Attorney Richard Robinson for the applicant, was uploaded to the portal on April 8th and will be added to the table of record. Any objections? Thank you. As we move forward, this is the process that we'll use for the hearing. The applicants will be allowed to present their direct testimony, and we will ask any questions that we have of the applicant relating to the application. Then we will hear from the public and any public officials, if any, decide to attend. I reserve the right to, depending upon how many people are testifying, modify the order in the interests of time. I would also like to advise the applicants that we may ask questions related to your application that you may feel have already been addressed in some of the documents submitted as a part of the review process. Understand that we do this simply for the purpose of understanding that the public has access and the ability to hear the details of this application and transaction. I want to reassure you we have already read the application, all your supporting materials, and pre-filed testimony. At this time, I would like all individuals who are going to testify or might testify on behalf of the parties, this does not include public comment, to stand, raise your right hand to be sworn in. Thank you. And also, please remember that prior to providing your testimony, make sure that you state your full name and adopt any testimony that you have pre-filed. So at this time, unless there's any questions, the applicants may now proceed with your testimony. So if you'd like to produce an opening statement or adopt your testimony and added any additional information, please do so. Okay.
Do you have an external mic on your table? No. Is this an external one?
I don't even know if they're on.
Is this the only mic?
For the podium,
But there's no mics for the table?
there was supposed to be another mic from West Hartford.
Okay. So if anybody can't hear, come up here.
Do you want me to stand?
Do you want us to?
Thank you.
Would you prefer that I stand at the podium?
It's up to the hearing officer.
Be easier to hear.
What was?
Yeah,
Ah.
sorry.
If you're having difficulty hearing in the back, you can please move to the front, and we can
Take the
hear
mic
better.
off the podium. It's a wire. Okay. Okay.
Sir.
Because I don't.
All right, yeah.
Yeah, I think these are hardwired for recording.
Okay, good afternoon. My name is Denise Peterson, and I'm the president and CEO of Heber Senior Care, and I adopt my pre-filed testimony. Thank you for this opportunity to come before the Office of Healthcare Strategy to present information to support our Certificate of Need application. In addition to my testimony, I have members of our leadership team from the Heber Senior Care, and they will be testifying. Dr. Ava Panula, our hospital medical director, Dr. Martin Cooper, our psychiatrist-in-chief of the Behavioral Health Unit, Kathy Walsh, hospital administrator, and Lisa Livingston, chief financial officer. Heber Senior Care has a long history of being in the Hartford community, over 118 years. Today, we are seeking approval for a new hospital license for increasing our behavioral health beds from 22 to 38. This project clearly fills a state-identified critical shortage of psychiatric services for seniors in a state that is considered the 6th oldest demographically in the country. Approval of our Certificate of Need will provide a much-needed solution to benefit seniors coping with mental illness. In addition, our proposal directly aligns with the state-identified goal in reducing mental health emergency department visits by 5%, according to the Healthy Connecticut 2020 report. By approving our licensure change, Heber Senior Care will fill a critical gap for senior services while increasing access to care. Our behavioral health unit is consistently at capacity, which you will hear in today's additional testimony of patients that we've had to turn away from the state. There's a critical shortage, as you know, of services, and UConn's report in 2014 identified as the Aging and Disability Resource Center Older Adults and Behavioral Health Asset Mapping. Heber Senior Care's Behavioral Health Unit is co-managed by Dr. Martin Cooper and Dr. Ava Panula. Dr. Panula is employed geriatrician with more than 30 years experience serving our community of seniors. Heber Senior Care has a contractual relationship with Connecticut Mental Health Specialists since 2005, when our behavioral health unit was opened. Connecticut Mental Health Specialists is the state's largest clinical consulting-owned psychiatric group and leaders in mental health care since 1997. Dr. Cooper is the psychiatrist-in-chief and co-manages the unit with Dr. Ava Panula. Heber Senior Care's Certificate of Need application is aligned in a preferred approach recommended by not only the state, but in many articles across the country. Thank you for granting me this opportunity to testify on behalf of Heber Senior Care's Certificate of Need application.
I'm Dr. Martin Cooper, and I adopt my pre-filed testimony for the record. I've been the psychiatric director of the Behavioral Health Unit since it opened in 2005. In in the 14 years that I have been there, I've seen the need for the services we provide continue to grow. The unit is almost always full, and there are many days we have had to turn away as many as half a dozen patients because there are no available beds. In fact, today, the unit is full, and in the past 24 hours, we have received 17 referrals for admission that we could not consider or accept. I am also aware of many times when patients have had to wait for days in emergency rooms or in nursing homes being maintained on one-to-one supervision because there are no available geriatric psychiatry beds in the entire state. The behavioral health unit receives referrals from nursing homes, assisted living facilities, emergency rooms, medical hospitals, congregate housing, and private doctors' offices. Referrals come from as far away as Stamford, Mystic, and Putnam, a testament to the lack of available beds that are closer. And with the aging of the population and the prevalence of dementia and other psychiatric disorders affecting the elderly, the need is only going to increase. We owe it to our fellow citizens who are in their declining years that they be able to access the help they need. I hope you will approve the certificate of need. Thank you.
Good afternoon. My name is Dr. Ava Panullo, and I adopt my pre-filled testimony into the record. I'm the Chief Medical Officer at Heber Senior Care. Heber Home and Hospital, Inc. has served the community for over 100 years. We have dedicated our service to the care of the infirmed, vulnerable older adult before population management, which was a catchphrase or old, was popular. I have dedicated my career to serving our aging community. I have long advocated for a holistic team approach to their management. The organization recognizes the changing needs of the Hartford community as well as the entire state. For us, the path is clear. Create a unit that can manage the psychiatric as well as the basic medical needs of the older adult, especially those with underlying dementia. Our unit attempts to do just that. By co-managing medicine and psychiatry, together we produce a better end result for the affected patient. We establish goals of care and treatment with fewer discharges to the ER for hydration, antibiotics, and respiratory management. Our goal is to address the psychiatric needs of the patient while the medical team maintains the physical health of the patient. Both psychiatry and medicine are on the unit multiple times daily with structured rounds, which also include nursing and pharmacy. The team approach allows better communication and shared knowledge, which improves high reliability and patient safety. We focus on the older adult with their specific needs. We are in tune with older adult physiology as well as aging physiology. We are comfortable taking care of those with underlying dementias as well as other neurodegenerative disease states such as Parkinson's disease. We recognize the challenges that accompany those persons with dementia and behaviors. We also understand that families are an integral part of the care process and make every effort to communicate routinely with them whether via phone or with on-site family meetings. We are in tune with developing a safe discharge plan and smooth transitions of care for those who are not able to advocate for themselves. There are many holes in the delivery of psychiatric care. We are attempting to fill one of them. Thank you for giving me the opportunity to testify in support of Heber Senior Care CON application.
Good afternoon, members of the Office of Healthcare Strategy. My name is Kathy Walsh, and I'm the VP of Nursing and Hospital Administrator at Heber Senior Care. Thank you for this opportunity to provide testimony, and I adopt my pre-file testimony into the record. We at Heber Senior Care provide compassionate and quality care to both our patients and their families. This care is reflected in the various letters that we've received from patients and families, and I will share one letter later, but first I would like to focus on our quality metrics. Our metrics have exceeded both national and state benchmarks for restraints and seclusion. This means that the use of our restraints and seclusion is very low compared to both national and state rates. As a matter of fact, our restraint rate is less than half of what national and state rates are. Our seclusion rate is over 10 times smaller than state and national rates. You may ask why this is so, and I really attribute it because our staff take pride in their ability to de-escalate patients, calm situations, and talk to them and really understand what's going on with them. Some of our staff have worked in the hospital for more than 30 years, providing nothing but exceptional care to our patients. They generally care for every patient, focusing on their individual needs. We also have great scores in our transition of care record. This is the record that provides the next provider of care on how they would take care of the patient. So there's a seamless transition in the process. We again score significantly higher than state and national rates. It provides the necessary and important information for our next providers of care. We also have great scores on patients discharged on multiple antipsychotic meds, and it's only really to the diligence of our medical providers who manage our medications for our patients and try to be better than the standards of practice. I attribute these better than state and national outcomes to a small team that strives to make decisions for their patients, works well together, and can provide the best standards of practice. I want to take this time to share a short letter from one of our patients from his son. His son was another healthcare provider, and the patient was admitted to our unit. He had a very rare form of dementia in his early 60s, not an age that you want to struggle with this debilitating disease. And his son describes the care that his father received far better than I could tell you, the care that the staff provided. The letter exemplifies the compassionate care that our staff provides daily to our patients, even at the most difficult times in their illnesses. We know that dementia affects all types of patients and their families, and there are no exclusions from this growing disease, and it is heartbreaking and difficult for all families to see and our staff to watch. Here's the letter. My father, Larry, was admitted to Hebrew Senior Care Behavior Unit this fall and passed away recently in the medical unit after developing sepsis secondary to posterior cortical atrophy. This is the rare form of dementia. Your staff saw him at the worst possible times of his life when he was confused, agitated, and aggressive due to the progression of his disease into its late stages. I am his son, a firefighter and an EMT, and my experiences have shown me the worst and the best of medical and behavioral facilities, care, and medicine. Your facility, your staff, your leadership is among the best I've seen, and I feel lucky to have had the opportunity to be with my father in his final hours in your hospital. We were guided through decisions our family had to make with great care and respect, and we were given the information to make the right decisions with the best information the doctors and the nurses and nurse practitioners had at the time. In the end, my father died peacefully, surrounded by his family in a way that brings great comfort to my mother and our family. We didn't always catch a name or a last name, and the experiences are too numerous to collect, but all of the people we worked with at Hebrew Senior Care were exceptional, patient, and understanding, and I am inspired by the level of care provided by your staff. In the postscript, he had highlighted a few people and experiences that we remember going above and beyond. This letter was written to Denise, our CEO, and he put, "You are a leader of a very capable team. I hope this letter does some good in return for the great care that we have received from you, with the greatest appreciation." So with that, there are many families that dementia does not touch. This is a growing population for our society, and we need to provide additional placement and hospitalization options to help patients and their families. I wholeheartedly support the expansion of the Hebrew Healthcare Senior CON application.
Good afternoon. My name is Lisa Livingston. I am the Chief Financial Officer of Hebrew Senior Care. I adopt my pre-file testimony into the record. I oversee the financial operations of Hebrew Senior Care. This proposal will positively impact our organization. While there are some initial startup costs, including renovation and outfitting the space and adding staff coverage, there are no financial concerns with the proposal. With this additional behavioral health beds, we will operate with a positive financial contribution. The leadership team and board have reviewed, vetted, and accepted the proposal. Thank you for the opportunity to testify in support of the Hebrew Senior Care CON. Thank you.
Mr. Hearing Officer, that concludes the testimony, and I take it from the agenda, if there are questions, that's the next item on the agenda.
Thank you. Do we have any public testimony? No public? Okay.
Good afternoon, and thank you for giving me this opportunity. I'm Pamela Atwood, and I'm the Executive Director of Colebrook Village at Hebron, which is an assisted living in Hebron, Connecticut. I would love to tell you that it was a very long drive, but for 15 years I made this drive coming the opposite way because I'm also a former staff member, in full disclosure, of Hebrew Healthcare, and I worked very closely while they developed the current behavioral health hospital program. I've also been a consumer of their services, as my mother-in-law had Parkinson's disease and passed away last November, and Dr. Panulo lovingly cared for her throughout the end of her life. So I come with bias, but a special bias, and that is with knowledge. As the Executive Director of Colebrook Village, I can tell you that this is an ongoing need, a need that will also increase exponentially as time goes on. The need for geriatric psychiatric care in this state, as they've already stated, is substantial and growing. I'm also a certified dementia practitioner, and even just from the Alzheimer's Association, we know that every 65 seconds, another American develops Alzheimer's disease. That's just Alzheimer's. That's not all of the other rare disorders and dementias, of which there are 75 to 100 different kinds. In the 10 months that my community has been open in Hebron, we've referred 4 of our residents for treatment at the Behavioral Health Hospital. So far, unfortunately, because they're so full, only one of them has been able to be admitted there. That resident became so well cared for that she didn't need us anymore and went home with her family. So as much as I would like to say that this is a great partnership, you're causing me my residents. No, I'm only kidding. We have a resident who was just referred last week and could not get into the unit. He spent, unfortunately, 4 days in a hospital emergency department where he was given all kinds of different medications. He eventually was admitted to a different psychiatric hospital, and unfortunately is now being seen by a neurologist and a number of other specialists, including rehab specialists, because he came out so deconditioned And we are questioning whether or not the medications that he was given are affecting his ability to ambulate back to where he was at baseline. So here's a gentleman, because of his dementia, who had a psychiatric episode and had need for psychiatric inpatient treatment, and instead we get back this train wreck of a medical situation to try to manage in the assisted living community. Assisted living, for those who maybe aren't aware, does not provide skilled nursing care. We contract out with home health agencies and provide some supportive care to help people who need some minimal assistance. We are not, by any stretch of the imagination, providing 24-hour skilled nursing care. So that's very difficult and tenuous for folks who are otherwise at risk of costing the state a lot more money, just because of the cost differences between skilled nursing and assisted living care. We also know that 1 in 3 Americans right now is dying with some form of dementia. And to put an idea of what that looks like, that is more than breast cancer and prostate cancer combined. Imagine if breast cancer and prostate cancer eventually also created such a psychiatric disability that patients with cancer were fighting with their caregivers, refusing their chemotherapy and hitting the people that they love, not recognizing the people that they love, and stating that they didn't remember being in their house or wanting to go home. These are very difficult situations for millions of Americans as caregivers as well. And I could speak endlessly on that, but I'm sure my time is close to up. So I thank you for your consideration of this certificate of need, and I congratulate Hebrew Senior Care on their efforts going forward, and I know that you will continue to serve the seniors in our state as beautifully as you have done for over a century. Thank you.
Good afternoon, and thank you for giving me this opportunity to speak. My name is Debbie Kleinman, and I am the chair of the board of Hebrew Senior Care. I've served on the board for approximately 13 years and have relied on the services of this storied Jewish agency for my family. My in-laws and my mother use the hospital at Hebrew Senior Care. My mother utilized the services of our geriatrician, who happens to be sitting here. And my mother and mother-in-law resided at Summerwood, which is our assisted and independent living facility. Today, however, I want to speak to you, excuse me, as a consumer of these services. My mother was cared for by Dr. Panula while being part of a continuum of services that focus exclusively on senior care. As a Holocaust survivor, it is no surprise that my mother suffered from depression and anxiety throughout her adult life. It was reassuring to know that Hebrew Senior Care had the appropriate services available if she needed treatment. I am confident that the expertise and care that they provided allowed my mother to live her life, her last years of her life, happy and content, always smiling and laughing. I have personally seen the important role that Hebrew Senior Care plays for families. Their expertise provides calm and reassurance during what can be the most difficult times for families to plan for. Given the gap in behavioral health services that exist in our state for seniors and the demographic aging of our state residents, approving the CON application will fill a critical need that our state has identified. Thank you.
If there are no questions, I'd like to make a brief closing. My name is Richard Robinson, and I'm the attorney for Hebrew Senior Care. We've had a very rousing presentation of the testimony today, and I can't conceive of an application more worthy than this one. But all I want to do is focus on what your unit has to decide, and that's the guidelines and principles in section 19A 639A. And I want to tell you what you probably already know, and that is that the exhibits, as well as the testimony in the record, more than establish that each and every one of the guidelines has been satisfied, and that the applicant is clearly entitled to the relief it's seeking.
Thank you. If there's no other public comment, I'm going to go off the record for a couple minutes. Thanks. Go back on the record now, and the office has a series of questions that we'll ask the applicant. First question is, please describe why you would like to terminate your chronic disease license.
Thank you. The question was, why do we want to terminate the chronic disease license?
Yes.
So I've been the CEO and president for 11 months. And when I arrived at Heber Senior Care, they have 2 hospital units. They have a medical unit and they have a behavioral health unit. The medical unit has the capacity for 23 beds. Behavioral health unit has the capacity for 22. In looking at the medical unit, it was originally put in place to care for patients who were in the long-term care facility if they had pneumonia or dehydration. So instead of going to the emergency room, they could come down to the medical unit, receive hydration, receive respiratory care, and some basic medical care. The long-term care facility could no longer support, or really, essentially never really supported that capacity of 23 beds. On average, they were running a census of maybe 5. So think about the expense of hiring medical staff. You need physicians 24/7, your nursing staff, your nursing assistants, and not having a consistent census or having to send the staff home when the census was 0. So what happened about 2 years ago is our strategy officer worked with Masonacare to create the Connecticut Senior Hospital Alliance in hopes that we could have the paradigm shift where elderly patients would come to the medical unit and be cared for low-cost, high-quality care. That paradigm shift is hard for the community and physicians to make, and despite a very wonderful effort by both organizations to create this, partnering with physicians, going out to United Healthcare and other commercial insurance providers, we just could not get the census to where it needed to be. So the census, the unit is closed more than it was open in the 11 months that I've been there. And I quickly realized, having been in healthcare for over 36 years on the acute care side, that while the concept is a good concept and makes sense, I don't think the medical community is ready for that environment. In addition, we did not have in-house capability to provide a stat, chest x-ray, respiratory therapy to come stat. So in realizing that and doing the research, our behavioral health unit that was turning away over 100 patients a year, I realized that the behavioral health unit was the way to expand. So we did the research, we met with the Department of Public Health, we told them we wanted to expand our behavioral health beds and what did we really need to do. And the recommendation was made we needed to sunset our chronic disease license and apply for a new license for hospital for mentally ill. And that's exactly what we did, and it supports the research and it's in alignment with the testimony that you heard today. And so we feel that this is the right direction to go in. I think in the future, maybe small boutique medical hospitals may be something of the future, but for now, there certainly is a growing need across the country and specifically in the state of Connecticut for geriatric behavioral health.
Thank you. Can you clarify, after the transition to reaching out to the community hospitals, did the census increase at all, or did it continue as you had noted previously?
It did. I think Dr. Panula can speak. We did get a few physicians from ProHealth to specifically admit to the unit. But we could not get the census. I would say the census was around 3. Some hospice patients, again, we could not, and I worked with ProHealth myself. I met with physicians in the community. Our team here did a yeoman's effort of meeting with the physicians in the community, but again, the consistency wasn't there. So we've ran a census. The unit essentially is not, there's no patients there. There have been no patients for several months. We average maybe 1.5. Not sustainable. And what types of conditions are you able to treat in the acute unit? So in the acute unit would be mild congestive heart failure. We are able to take IVs, do blood transfusions, hospice care, respite care, mild pneumonia, mild COPD. Again, we do not have respiratory therapists. We would have to contract with respiratory therapy department. We do contract with a lab. We do contract for x-rays, but we don't have that full service capability to provide the full services that medical patients need.
Thank you. How many of your behavioral health patients are currently treated for a condition in the acute care setting during their stay?
Well, I'll let the physician speak to that, but we do not admit. What happens is the behavioral health patients stay in there if they have a medical illness, then they're cared for by the nurses and the physicians there. They don't go to the medical unit because their primary diagnosis is still behavioral health.
Sorry, Karen. So typically what would happen is someone is admitted to the behavioral health unit for their psychiatric illness. And then, as always, these folks do have a laundry list of medical problems. If they start to decompensate, then again, it's our discretion, but we are usually being proactive and preemptive in treating these people before they get really bad to where they have to be sent out to the emergency room. So the condition would be a pneumonia. If we can catch someone early, we can start antibiotic treatment and respiratory nebulizer treatment, et cetera, before someone gets really bad, to where they get septic, to where now it becomes a stat, a 911 out. So it's more seeing somebody on the unit after they're admitted. We save a lot of people from going out to the emergency room because we are being very proactive.
Thank you. And what are some of the other providers in the area that would offer acute services that are being discontinued?
I didn't understand.
Can you clarify that, say that question again?
Can you name some other providers in the area that offer acute care services?
When you talk about acute care, you're talking about the hospitals?
Similar to what are being
Absolutely.
discontinued,
So
yes.
St. Francis Hospital Medical Center, Bristol Hospital, Hartford Hospital, Central Connecticut, Mid-State Medical Center, Yukon, Manchester, several hospitals in the area.
Thank you.
According to your application, the geropsych population has unique needs, and best practices for this population differ from non-geropsych patients. Can you describe your target population and the source of admissions?
Target population.
So most of the patients who come into the behavioral health unit either are suffering from the behavioral manifestations of dementia, or they have primary psychiatric diagnoses such as schizophrenia, bipolar disorder, depression, but are in the geriatric age population. As I said in my testimony, they come from all over the state. They come from acute care hospitals, from nursing homes, assisted livings. Many of them live at home and come through emergency rooms, from private doctors' offices, etc.
Can you explain some of the specific needs that the geropsych population has, including examples of the best practices of care for the geropsych population?
I'm going to pull it off the table. So some of the best practices can be actual clinical care, which I'll let Dr. Cooper talk about some of them, but there's standards of practice which we pull for Alzheimer's, dementia, depression, and we focus it all, well, Dr. Cooper focuses it all with that, but there's many other pieces. We do occupational therapy that is very focused on the geriatric population. It's specific to that age bracket. We have nurses who have been educated even in older adult practices. We have best practices with colors for environmental, for safety issues. We're looking at, for the new unit, all specific beds, furniture, everything environmental also. Nursing practice, we'll look at best practices, look at what's the safest We do medical rounds, which is a best practice for our patients every day. The medical physician meets as well as the psychiatric physicians meet, and they'll look at practices and work together. Part of our unique practices, really, they're co-managed together, and we're such a small organization that they work very well. Their offices are close. We work very well together as a team with the nursing staff. The nursing staff can get to Dr. Cooper or Dr. Panullo in seconds, and they will address all the specific needs. Do you have anything else?
Well, I believe you also asked sort of what are some of the unique needs of the geriatric population. They certainly tend to be more medically fragile than a younger population. They have most of the patients have multiple medical comorbidities. They often come in on scores of medications, and that's one of the things we look at always, and we've had a number of patients who've come in with behavioral symptoms that we were able to find out were as a consequence of some of the medical medications that they were taking. And our treatment was basically just to take them off of some of those medications and not add any new ones. So it's really a comprehensive look at these very complex patients. Did you want to?
No, I just wanted to add. So I just wanted to add, reserve capacity. We all have reserve capacity, but as you get older, and especially with our frail older population, and then add a layer of dementia, these folks don't have a reserve capacity. So when they drop their blood pressure, it becomes a lot more potentially egregious than if you or I did that. We can recover better and faster, and these folks can't. So what we look to do together is anticipate potential problems, recognizing that if psychiatry needs to adjust psychiatric meds, that's part of the reason why they're there. I know, and my team also understands, that these meds also have side effects. So if I see that and I see what the medical medications are, I can then make adjustments in anticipation of a potential problem to avoid it from happening. So that's one of the, again, that holistic approach to taking care of this fragile population.
So I know that your application talked about the holistic approach continuing, but if the proposal is approved, can you provide specific examples of how your facility will be equipped to better treat the geropsych population going forward?
So I'll start. So again, again, what we have been talking about is the team approach. That's the holistic approach. So it's not just me working in my silo or Dr. Cooper or the nurses. We're all talking to each other, and it's a constant interaction. So we have set rounds every day, but it doesn't end there. So if there's a particular problem, an adjustment, we're constantly talking to each other to fine-tune, to tweak, if you will, and make adjustments during the day. So it's sort of an ongoing process.
So you asked how our environment would be designed to care for the geriatric patients, and as Kathy mentioned, the furniture and the beds in a lower position. We would balance sensory stimulation, larger numbers, so if they did need to use the phone for any particular reason, they would have the larger numbers there. Again, colors and textured objects, so the floor, the patterns of the floor for ambulation and for safety. So again, making that for the dementia, Alzheimer's population, a memory board in the room as well. Again, always keeping in mind that we have to keep the regulations so that there is a safe environment and ligature free.
Right, and going along those lines, the calming colors, the larger phone number, or the numbers on the phone, etc., or the specific furniture for that population, would that be throughout the facility or just the additional 16 beds?
So in our current existing behavioral health unit, we have made changes in the beds, the colors. We've done what we can based on, you know, the fiscal opportunities that we have and some donations, and so we're ligature safe. We had several donations, so we've done that as well. And again, with the occupational therapy there and keeping it that safe as it is on the other side.
Okay, thank you. So what other geropsych treatment facilities or facilities that treat geropsych patients are in your service area?
So the other in our catchment area, Bristol Hospital, as you know, it has recently opened a geriatric behavioral health unit inpatient. I believe their capacity is at 15. I believe Manchester Hospital as well. Masonic Care has an inpatient behavioral health unit under their licensure. And then, as you know, several of the hospitals throughout the state care for psychiatric patients from teenagers all the way up through elderly adult that don't have a specific identified geriatric behavioral health unit. It's from a wide range of ages. So that being the Institute of Living, Waterbury Hospital, St. Mary's, Mount Sinai, in Hartford as well.
So you're seeking to establish a mental health facility focusing on the geropsych population. Can you talk a little bit about your impression that there's a shortage of geropsych beds in the service area and your experience with that?
Yeah, it's been my experience that because I work on the unit every day, that it is almost always full, and we get referrals virtually every day that we turn away because we don't have available beds. In fact, sometimes we get referrals from say, emergency rooms where, you know, the person on the other end of the phone is pleading with us and telling us that they've called every place in the state and there isn't a bed in the state, and they're forced to keep the patient in the emergency room sometimes for days on end until a bed opens up somewhere. And as I said in my testimony, you know, in the last 24 hours, we've had 17 referrals that we turned away because we were full.
And I think the last year, we were around 170 that we turned away. I'm going to tell you that in the last 3 months, we're approaching many. I mean, we have 17 in 2 days now, so it's clearly been rolling and gathering momentum.
You know, and I know in our filings you have the statistics and the specific information regarding the number of patients we receive. As you know, we receive patients a lot from New London, from Stanford, from all over the state, again, specializing in geriatric behavioral health.
And going along the lines of the filings that we have received, you had a Diamond Healthcare perform the initial bed need assessment. Why did you choose them specifically?
So Diamond Behavioral Health I've had experience with, and they've been in business for over 30 years, and they specialize in behavioral health services across the United States. They come into multiple facilities, acute care settings, and provide their expertise and knowledge in looking at quality. They look at market share. They look at opportunities to enhance our policies, our practices, and provide that best practice standard. And if you look them up, I chose them because they are one of the renowned companies that does this with their expertise. And we have partnered with them. We've signed a 3-year contract for them to come in and help us with that to ensure that we provide the highest level of geriatric best practices across the nation.
Okay, so now that you said you had a 3-year contract with them, Has Diamond Healthcare conducted any other reports regarding the geropsych population need at your facility besides the 2 that you've already submitted?
There are no additional reports besides the reports we submitted. They're coming in to partner with us on providing, enhancing the quality of professional practice.
And did you conduct any other types of geropsych bed need analysis either on your own under a different provider?
We did not. And Diamond used the Chime data. We use the SAMHSA data as well.
On page 11 of your second completeness response, you're projecting a decrease of over 4% in the percentage of Medicaid patients between fiscal year 2019 and fiscal year 2020. And I was just wondering if you could talk a little bit about that.
Give me a second to get to it, please. Yeah, I do. 2 seconds, please.
You said that was
Second.
page 11 of the second?
one?
Yes. Yes, on page 11 of the second completeness response.
Sorry. Got it all there. Break to find it. I mean, a break to find it. Anna, which question was it?
It's under question 9. It's directly related to OHS Table 6, the applicant's current and projected payer mix.
Yep. Okay. You got it, Lisa? Okay. Can you please repeat the question now that we have the data?
So the question is, why are you projecting a decrease of over 4% in the percentage of Medicaid patients between fiscal years 2019 and 2020?
Table 6, correct? Lisa? Lisa? She's seeing it. Table 6.
So I can just begin
And we
by
can-
saying our current mix, if you looked at our payer mix for Medicare and Medicaid, we primarily see more Medicare patients. It's not to say that we turn away any patients, whether they're Medicaid or what insurance they have, or if they don't have insurance. So going forward, we can look further and detail and get back to you on that question, but we are really running anywhere from a 95% Medicare, 5% to 4% Medicaid. Will that increase? Our projections were based on the support from the assessment we did with Diamond Behavioral Health, based on our current payer mix, and it was just projected going forward. If that changes, that doesn't change the need or the care that we would provide in the state for geriatric behavioral health, regardless of their ability to pay for insurance.
You want?
So the other thing relating to that percentage ratio change, when Diamond Health came in and they did their pro forma, their national averages were a bit different than our historical averages. So when we layer on their pro forma at their ratios onto our existing numbers, it drops kind of how the ratio mixes because they did the pro forma and they were using their national ratios. Not knowing exactly what the future holds in terms of that, we took their pro forma ratios, mixed them with our historical ratios, and that's why you show a drop. As time will tell, there's, we could stay consistent with the mix between Medicare and Medicaid, but utilizing the Diamond expertise on a national level, it created the drop in the Medicaid versus Medicare. So that's kind of how the ratio mixed out with our historicals and their pro forma all combined together.
Okay, thank you.
So you provide inpatient behavioral health services to geropsych patients, and Dr. Panullo mentioned some of the most common diagnoses that you currently see. Can you give us just a brief summary of the most common diagnoses that you currently treat?
Of medical.
On the behavioral health.
Right, but of psych, so that would be Dr. Cooper.
So Dr.
sorry,
Cooper.
'cause you had mentioned some of
Yeah.
them.
So the most common diagnoses would be dementia with behavioral disturbances, various types of dementia, certainly Lewy body dementia, vascular dementia with behavior disturbance. And as I said before, older people with common psychiatric illnesses like schizophrenia, schizoaffective disorder, bipolar disorder, major depression, anxiety disorders.
Thank you. Do you expect to be able to treat or have the capacity to treat any additional diagnoses beyond what you currently do in this setting?
Do you have a specific diagnosis in mind? I mean, I think given the expertise of Dr. Cooper and his practice that's been in existence, we can treat almost any disorder unless they are truly have an underlying medical illness or they are extremely combative where they would need more emergency care.
Can I just add something? So I think part of this is the layering on. So you may have someone who's a chronic schizophrenic or maybe has bipolar as a young adult, now ages. Now we develop dementia. So that adds the extra layer and an extra problem that you didn't have when they were 50 years old. And now at 80 years old. So it gets very complicated because it's like an onion. You're peeling away the layers, but there's always now the dementia adds that extra problem, an extra degree of difficulty, if you will, in taking care of somebody.
Thank you. And actually kind of along those lines with the complexity, how will the addition of the outpatient services at the facility impact the way that the services are being delivered now and are planned on being delivered?
Outpatient psychiatric services?
Yeah.
So we're planning on the outpatient psychiatric. So,
Do you want to think?
Would you repeat that again, please?
So how will the addition of the outpatient services at the facility impact the way that services are going to be administered?
On the inpatient unit?
No, our-
or-
Here, let me,
Oh.
here,
Behavioral
we can start.
So we currently do not have an IOP program, but in the pro forma, you saw that our plan is to open an intense outpatient therapy program. What this will do is it'll complement the treatment so that when patients do go back, as the testimony was, to an assisted living or to home or to a long-term care facility, they have the ability to come as a day patient or an outpatient into the treatment program. I believe we have a ramp up of seeing 5 patients and going up to 10. This will also help support, we do have a day care center program where we do take care of patients, and we have a medical model there where we have nursing staff with the patients as well. So this will provide that continuum of care so they don't go home and we don't lose that plan of care. Oftentimes patients are discharged, and the reason we have readmissions both on the medical side and behavioral health side is because of compliance and not being in an intense program that keeps them out of the hospital, because the goal is really to treat them outside of the walls of the organization.
All right, thank you. And how are you planning to maintain the quality of care given that you're expecting an increase in daily census?
We will maintain the same standards. Our staffing ratios will be the same that they currently are. Our oversight and our quality reporting and tracking of data will be done and presented monthly. That support will be augmented with Diamond Health's behavioral expertise. We have key performance indicators that we'll be trending and tracking. We track restraints and all of the quality indicators that Kathy Walsh, our Vice President of Nursing and Hospital Administrator, talked about.
I want to say one thing. I just want to add one thing.
Thank you. And actually, follow up on that. So what, if any, staffing changes are you anticipating and able to adjust to the increased census?
We will be hiring additional staff and training them for the additional patients. We know there will be a ramp up, and we have staff that we've hired in now that we could move to the new unit on a couple shifts already. So we have some of our medical staff still left who are been trained in behavioral health. So we have some staff, and then we'll be adding to that. But I also want to address a little bit with the quality measures. We do also have to report to CMS all our quality measures, and there's many, many measures. And as a matter of fact, we actually, even though CMS has dropped some measures because they're best practice, we still monitor them and keep them on track and make sure we still keep giving best practice. So there's a slew of measures that CMS really, with their panel of experts, has focused on. Did I answer enough of your staffing questions?
Thank you. In your pre-filed testimony, you mentioned that hiring a case manager or a discharge planner in June of this year. Would this be a full-time position?
We have actually, we will be hiring a case manager and sharing that resource with Masonic Care, with their behavioral health unit, so it will be a full-time employee. We will have that person, he or she will be half-time at Heber Senior Care, half-time at Masonic Care, and we are hiring a full-time equivalent for a discharge planner that will augment the social services that we currently have. And I believe that's in the staffing model that we presented in the pro forma.
All right, thank you. You also mentioned that this case manager or discharge planner would be more efficient in managing patients in a timely manner, specifically for those transitioning to the outpatient services. Can you provide some examples of how that efficiency will work for patients?
Sure. So, we talked a little bit about team meetings and rounding every day. We do have challenging patients that their length of stay can be upwards of 60 days based on nowhere to place them. So in combination with the discharge planner, discharge planning will begin on admission. We will identify those needs early on and work diligently through processes and having that additional support of the discharge planner and the case manager who has the knowledge and expertise to support our social services department will help to transition those patients out of the hospital sooner. The benchmark for the average length of stay is between 15 to 18 days. We don't want some patients are there 60 days plus. So again, our goal is to get them back to the facilities that they came in. And I think you've heard testimony regarding the importance of getting them back to the assisted living or to their families.
All right, thank you. And will this position, the case manager, discharge planner, and how they interact and work with the social services unit, will they be taking into account, as a part of the discharge plan, wherever their ultimate destination is, some of the social determinants of health and other factors impacting the patient's ability to thrive in a lower level of care?
So the goal of our care at Heber Senior Care is an interdisciplinary model. So the interdisciplinary model includes nurses, social workers, occupational therapists, psychiatrists, hospitalists, gerontologists, and the team meets and puts together and puts forth a plan of care. So that plan of care for that patient involves the entire team. So the entire team's expertise, including social work and discharge planning, case manager, and the physicians work collaboratively together with the nurses for patient placement.
And just to follow up on that, will the team take into account factors beyond their immediate diagnosis for treatment in the facility, factoring in other available resources, for example, a patient being discharged to home, limitations to their ability to remain in that environment potentially?
Yes, so if they were to go home and they needed occupational therapy, physical therapy, DNA, that's all looked at. So we would never discharge. We look at a seamless transition of care to the post-discharge environment, whether it's home or assisted living. There'll be a discharge plan from the physicians, and I'll let the physicians speak to that.
And we are in fact mandated by CMS to provide a safe discharge plan for every patient that's admitted to our unit, and so we pay a lot of attention to that. In fact, I would say most of the patients who do have extended stays on our unit are there precisely because of the need for a safe discharge plan, which in those cases can be very difficult to achieve and takes a lot of resources.
Thank you for that. On page 22 of your application, you note that geropsych practitioners are able to provide more cost-efficient care as they can recognize some of the potential comorbidities you've talked about. Can you provide a little bit more in the way of how these efficiencies can be realized? You mentioned a couple examples earlier.
Okay. So we talked about the hypertension example, but another one which we all pay close attention to is weight loss and also dehydration. And so if we see someone who's come in, for example, on Lasix because they have edema in the legs, and they're coming in with their psychiatric diagnosis, and part of that is we're paranoid and we're not eating and drinking, we kind of recognize that if we continue the diuretic, which will potentially make you dehydrated, we're going to get into trouble. So if we keep a close eye on what their intake is, we start adjusting medications, and oftentimes we'll need, or the medical team will need, to hold the medication in lieu of laboratory evaluation or clinical assessment. And also then we work together with psychiatry to say, okay, if we can kind of med manage from the psychiatric standpoint, then maybe we can then reinstitute medications, because as they become less paranoid, less delusional, they're drinking now better, then we can start reinstituting medications. That would be an example. Do you want to?
Another example would be patients with dementia associated with Parkinson's disease. Those patients require very close collaboration between medicine and psychiatry, because the medications used for Parkinson's disease tend to worsen psychiatric symptoms, and the medications used for psychiatric symptoms tend to worsen Parkinson's disease. So, as I said, it takes a very close collaboration and finding the best combination for every patient. And if you're not working closely together the way we do, people don't have good outcomes, and they have prolonged stays and so on. And maybe one other example would be we see a fair number of patients with chronic pain syndromes and psychiatric illness. And again, that's another that requires very close management because of the interplay between depression, anxiety, and pain.
You asked about the efficiency example and access to care. So preventing patients from going to the emergency rooms and crowding. As you know, emergency room overcrowding is a problem throughout the state. And by having direct access to us as a behavioral health facility, that they can be admitted directly from the long-term care facility or assisted living instead of going to an emergency room, having an overnight stay or long stays, high cost to the healthcare system, as well as us being able to provide that safety immediately for those patients. So as our physicians have spoken to, you have an elderly patient in the emergency room, there's a lot of stimulation. It adds to their being afraid, it adds to their dementia, and just creates a longer length of stay. And as you know, some patients board in the emergency room for days. So we have a solution to that, and that's by expanding those behavioral health services and admitting directly to us.
Thank you for that.
You're welcome.
Can you please describe your current charity care policy?
I'm sorry, can you say that again?
Can you describe your current charity care policy?
So currently, the charity care policy, which is posted at the facility, requires an individual who's being admitted who falls within the charity care guidelines to fill out an application. The application is mandated by the state, the national poverty levels. So if they fall within the poverty levels, they would fall within the charity care program. We haven't had, I believe in the last few years, we've had one charity care applicant. That being said, we do not refuse care based on ability to pay. So we accept all patients in need regardless of their ability to pay, which, you know, if they qualify for charity care, they submit the application. If it's denied for any reason, we do have a process that they can rebuttal the denial. But regardless, we provide care irregardless of their ability to pay.
Can you, to follow up on that, can you tell me how you evaluate or how you determine if a patient falls within the eligibility guidelines?
So the application would have questions that are specific to their income level, and there is a table issued by the government regarding the poverty levels that they would need to fall within in order to be able to qualify for the charity care. So we follow the national guidelines in terms of poverty on that.
And how are patients made aware of this policy?
It is posted in the facility, so I believe it's posted at the admissions area.
And social worker.
And the social worker is also aware of it, so when they interact with their social worker, the social worker will make them aware of the policy as well.
Thank you.
And it's also, can we see what, it's also on our website too, so it's posted multiple spots in our website.
Thank you. And will it change as a result of this transition?
No, that the policy will not change. We do follow the national guidelines, and it will remain posted in all of the applicable areas. And again, we do not deny care for reimbursement sake, so we will accept patients regardless.
And you mentioned you've only had one applicant in the last several years.
We have, in my discussions with some of the staff, some of it is that people don't necessarily want to apply for the charity care. You know, there is a certain amount of pride in some of our patients. The social worker lets them know. We have had one applicant to it, but we have provided uncompensated care over the past several years, so we do accept patients.
Okay. And who currently reviews these applications?
Who does?
The CFO does. She's the CFO in the hospital.
You'll excuse me because I've only been at the organization for a few months, but that is part of my role, and I have not had an application since I started. So.
And are you going to continue to be the person to review applications?
We hope
Yes,
so.
we hope so.
I have every intention.
Thank you.
So can you please describe the current financial state of Hebrew Home and Hospital?
Yeah, so we've actually come a really long way in the last, since Denise started actually 11 months ago. As you're aware, the company came out of bankruptcy 2 years ago, and we were fortunate enough to hire Denise 11 months ago, and Denise has basically looked at every aspect of the organization for cost-cutting endeavors, for revenue enhancement. We are now on solid financial footing with a clear path to net operating income this year. We are becoming stabilized with our cash flow. Obviously, the additional units will put us on very solid footing and enhance our cash flow contribution to the whole organization. We're happy to say that we have made great strides over the last 11 months, and this would be just further enhancement to what's already becoming a success story for the organization.
Okay, and if you could just elaborate on some of the cost-cutting measures that you've done over the past 11 months.
So what we've done is looked at areas where we can outsource services. We looked at areas where we could consolidate or cross-train resources, looked at roles and responsibilities. We looked at every department where there could be some sharing in our medical unit in cross-training the staff to the behavioral health side. And really, this certificate of need and expanding the behavioral health beds will certainly add to the revenue for the organization. At the same time, it's about providing the quality of care. So in 11 months on an annual basis, we've been able to reduce expenses through a multi-pronged approach, and we've reduced them by $2 million. And that, based on our overall revenue, is about 15% of the overall operating revenue. We continue to look at outsourcing services where we can. Again, positions that we can cross-train or that are not needed. We looked at alternative opportunities to one-to-one staffing. There are ways with always keeping safety and quality at the forefront. And you heard from our Vice President of Nursing and Hospital Administrator that our quality scores, while reducing our costs by $2 million, supersede the national average. So quality and safety is always number one. Reducing expenses is something we all have to do in healthcare. As you know, it's very costly. So lower cost, higher quality, and we've been able to do that, and that's something that we will do ongoing.
And going along those lines, do you anticipate any type of cost savings associated with the proposal, or can you expand on that a little bit?
You know, we'll maintain our efficiencies. I think there will be some cost savings when we look at our length of stay and being more consistent in discharging patients within that benchmark of 18 days and opening our IOP program. I believe that there will be some efficiencies and cost savings there. So that's where we'll look for that. Coding, documentation, and billing is also an opportunity, as you know, with complex computer systems and codes always changing. We always look at that and make sure that we have efficiencies there.
Okay, thank you. On page 17 of your pre-file testimony, you state that you've received donations of $350,000, and you said that we have had to rely on our individual donors for our working capital requirements. Therefore, Hebrew Senior Care will have to initially depend on foundation grant support for the behavioral health unit renovation. Is the $350,000 separate from the $1,600,000 needed to fund the proposal?
Yes, it is. Yep, that's working capital that we needed for operational support. Thus, we're going to foundations for the capital renovations.
And so the $1,600,000, from my understanding, is for the renovations themselves. Do you anticipate needing additional funding to support the cost of working capital going forward?
Not when the unit's open, no. But the total cost, you should know, is the construction for the unit as well as the card costs for furniture, the beds, and dining room equipment. So that's how that number totals out. I should state, as the Vice President of Fundraising, obviously we will continue though to fundraise and request operating support. It may not be at the critical level we are experiencing today, but we'll always look to the community to help.
Okay, so the additional,
which always responds, the community.
You know, and I have to say something about community support, because being new to this organization, and I live in the other in Middlebury, I have to say I have never, in all my years, the support of the board, the support of the community, and the belief in Heber Senior Care is extraordinary. And they have always been there for us when we needed it. And when we reached out to key members in the community, they've stepped up to the plate. We recently had someone in the community say they wanted to help us with the renovations, and that they have a team of people who can come in and help us. So I'm proud to be part of this community. I respect and thank them for all their support, and especially, you know, our board, who has been there through thick and thin for us.
Okay. Thank you. I know that you just mentioned, and you mentioned in the application, some members of the community that have suggested gifts in kind or financial donations. How much money have you specifically fundraised for the proposal at this point?
As of today, I am waiting for CO1 approval in order to submit the applications that we have prepared. However, the two foundations that we are applying for, they do know we're coming to them. We've been in discussion. They have rolling deadlines, and they are waiting for our submission.
And so, given the cost of the $1,600,000 needed to fund the proposal, what type of contingency plan do you have if you're unable to secure the amount needed for the renovations?
If we're unable to secure the amount that we need, then we would look for other opportunities for funding, resources, and loans, etc.
How long are the renovations specifically expected to take, and when do you expect the full 38-bed geropsych unit to be available for patients?
So we have our architectural drawings. We have them in review with the Department of Public Health's engineering department to meet the code for licensure. The unit's infrastructure is there. We do have some walls to take down. We're estimating about 4 months from time of construction till we open. You know, construction sometimes the best laid plans, so you always have to kind of give a month or two. But aggressively, we're hoping to have the unit open by November. Again, we've been anxiously waiting for CON approval before we can go further, but we have had the architectural drawings completed, and as soon as we have approval, then we will begin. So the unit is intact. So it's a matter of expanding, consolidating, and meeting all the requirements for the new licensure.
And are you expecting that the inpatient or the outpatient unit, will begin at that time as well, or the outpatient services will begin at that time?
The outpatient services, I believe we have projected about 6 months into the opening of the unit. So in 2020, we would begin the IOP, and there's not much construction needed for that because it's a program that we have the space for.
Okay, and I know that we were just talking about the renovations and the renovations to the medical unit, to the unit itself. Will the renovations to the medical unit impact the patients currently on the behavioral health unit? And what steps have you taken to ensure limited disruption to your geropsych patients going forward?
So we're very fortunate that it will not disrupt the behavioral health unit. They're completely separated.
Are there any common areas that are going to be renovated for the proposal?
No, there won't be any common areas. However, the family waiting room area that we're creating is the main entrance for the hospital, so certainly families who are there to see patients on our current behavioral health unit can wait in that waiting area, and the entrance will have an admitting type area that can be shared. So if there were shared space, I would say it would be the family waiting area, conference room, and the admissions area.
Okay, great, thank you.
Just one last question. Sure. You had mentioned that as a part of your cost-saving measures, you will outsource some of the services, some of the providers that will be helping to treat your patients.
For any of these services that may be billed separately, how will you ensure that those providers are in network for your patients?
So let me ask a clarifying question. Are you referring to the Aetna and Blue Cross? Can you repeat the question? I'm not sure I understood what you were asking.
It's a broad question, but
Yeah.
for any insured patient for which the facility is in network, if you're bringing an outside provider in, how are you going to ensure that they're in network?
So that's the case manager that we have will screen in our admissions office, will ensure that they meet the criteria for admission and for care. That is the piece that the case manager has the expertise in, and they will work with our team to ensure that.
Okay, thank you. And that concludes the questions that we have for the applicant. At this time, we're going to go take a brief 15-minute or 10-minute break, if that's enough time for everyone, and we'll go off the record.
Okay. Great. Thank you very much.
And anyone in the public, if you do have any written comments or testimony that you'd like to submit in support or opposition of this application, you can do so via the contact information that is on the information sheet available at the check-in table. Does the applicant have any closing remarks they wish to offer at this time?
Thank you for this opportunity to come before the Office of Healthcare Strategy. I also want to thank the members of the public, which are really our staff at Heber Senior Care, for coming out to support us in this effort, and my leadership team. And I also want to thank, I know Madeline Francesi did the bulk of the work, and she can't say enough great things about the Office of Healthcare Strategy, for your support. I know we called you with a lot of questions. You were always there to answer them. We're thrilled to be here, and we really believe that this is the right thing to do for the state of Connecticut, for elderly patients. And again, we really want to thank you, because this was truly a collaborative project. So thank you, and thank you to the staff, my leadership team. I'm proud to be here. I'm proud of all of you. Thank you. Okay,
Thank you. So just to let everyone know, the record will be held open for this hearing until next Tuesday. So at any point prior to next Tuesday, if anyone would like to submit additional comments or testimony, they may do so. At that point, we will close the record.
Okay.
And at this point, we're going to go off the record until 6 o'clock to give additional public an opportunity to show and provide commentary on this application. So we're off the record right now.
Thank you.
And this hearing is adjourned.
Next steps, here we go.
Off the record.
Congratulations.
You too.